Hello, I'm Dr. Jeffrey Weber. I'm a medical oncologist at the Laura and Isaac Perlmutter Cancer Center here at NYU Langone Health in New York City. Today we'll be discussing some very important abstracts presented at the recent Society for Melanoma Research meeting in Edinburgh, Scotland. Two of them relate to rather similar trials of adjuvant therapy, and one is really a bit of a revolution, or I should say an evolution, when we talk about tumor-infiltrating lymphocyte therapy for metastatic disease. But let's get to the abstracts. There was an update presented by Dr. Dirk Schadendorf from Essen on the Keynote 716 trial, which was the large randomized trial of pembrolizumab versus placebo for patients with resected stage 2B, 2C melanoma. And we now, for the first time, had detailed information with probably 2 years of follow-up. And we had distant metastasis-free survival at 2 years, which was 88 versus 82%, clearly superior for the pembrolizumab versus placebo, hazard ratio of 0.64, and the updated relapse-free survival now at the third interim analysis, again 81 versus 72% and 9% absolute difference. Again, the hazard ratio was 0.64, which is, I think, quite good. And a subgroup analysis was now done for both relapse-free survival and for distant metastasis-free survival for the first time. And with the exception of the low tumor-infiltrating lymphocyte group, for every potential subgroup with prognostic value, clear superiority for both relapse-free and distant metastasis-free survival for the pembrolizumab arm versus placebo. Again, if we look at treatment arm, tumor depth, mitotic rate, those were all significant independent factors for relapse-free survival. And if you look at distant metastasis-free survival, it's what you got treated with, so treatment arm, and the mitotic rate, all of which I think continues to suggest that pembrolizumab is an effective therapy for patients with resected not only stage 3 and 4, but 2B and 2C disease. Now, we also heard for the first time from Georgina Long about the results of the BMS-76K trial, which was a somewhat similar randomized trial. This time it was a 2-to-1 randomization of nivolumab, the PD-1 antibody, versus placebo, 790 patients. And as you would expect, this was a positive study, just like the Keynote 716 study. Nivolumab reduced the risk of recurrence by 58%, so a very significant hazard ratio of 0.42, very nice data, with a p-value of 0.0001. And again, we had less follow-up, about 15 months per arm, than the Keynote 716 study, which started earlier. But the 12-month relapse-free survival rates, 89% versus 79%, not too far off from what we saw with Keynote 716, but a 10% absolute difference. And again, if you look at the forest plot, looking at benefit over the different subgroups, including T category, disease stage, clear benefit for virtually all of the subgroups. And now we actually had distant metastasis-free survival, and clearly there was improvement in distant metastasis-free survival, this time with a hazard ratio of 0.47. The safety profile, not really all that much different than what we've seen previously with nivolumab or pembrolizumab alone. The grade 3/4 immune-related adverse event rate was about 10%, which is what we've seen in Checkmate 238 in higher risk patients, and not far off from what we've seen in the early Checkmate studies like 66 or 69, where nivolumab alone was used. So again, we now have another new effective adjuvant therapy. Nivolumab, we already have an FDA-approved therapy with pembrolizumab, and I'm sure nivolumab will be going soon to the FDA for potential registration. Finally, we heard an update from John Hannon on a very nice randomized study, a phase 3 study of tumor-infiltrating lymphocytes in patients who had failed prior PD-1 versus ipilimumab as the control arm. And John's presented these data in the past, but he now presented an update, and this again was 168 patients, 1-to-1 randomization. Even in spite of its small size, it was a phase 3 study, and there was clearly a continuing advantage in median progression-free survival of 7.2 versus 3 months. The hazard ratio was a very impressive 0.5. And again, if you look at the best overall response rate, 49% versus 21% for the ipilimumab control arm. If you look at overall tumor regression, that is, in the swimmer's plot, looking at those who had tumor shrinkage versus those who didn't, 67% versus 35%. Again, very impressive. And if you look now for the first time at a comparison to, I wouldn't say a similar, but a comparison to a trial that used a similar patient population, the SWOG intergroup 1616 trial, in which patients who failed PD-1 antibody were randomly allocated to either ipilimumab, just as the control arm was in the John Haanen trial, or ipi-nivo. And so the comparison, which is really back of the napkin, is how did TIL do versus ipi-nivo in patients who had failed prior PD-1 blockade. And you're really comparing apples and oranges to some degree, but it's an interesting comparison. And in fact, if you look at the response rates, clearly higher at 49 versus 28%. The median PFS was only about 3+ months in the ipi-nivo arm of the SWOG 1616 trial, and as you recall, 7.2 months for the randomized TIL trial. So again, there's no question that TIL appears to be very active in a selected population of patients who can tolerate the significant toxicity that's been described well before of TIL. The 20% CR rate has been updated, and that's a very impressive number for TIL. And no new safety issues were seen in the updated analysis that Dr. Haanen presented. And again, looking at health-related quality of life, higher in those who got TIL compared to those who got ipilimumab. And again, I think this will eventually come to the regulatory bodies, and this will, I hope, represent a new treatment option for patients with melanoma who'd failed PD-1 blockade. Well, that's what we've got from the Society for Melanoma Research 2022, and please feel free to call in with comments and questions, and I thank you very much for your time.